So,
Morning.
Gita, maybe you want to go ahead and get started?
Sure. Good morning, everyone. I'm here to introduce Dr. Sunil Ghelani, who is a staff cardiologist and assistant professor in the Department of Medicine and Pediatrics at Harvard School since 2016. He is part of the Division of Cardiac Imaging and is intricately involved in echo, cardiac MRI, and cardiac CT. His research interests include ventricular function and using cardiac imaging and circulating biomarkers for risk stratification and outcomes prediction in patients with complex congenital heart disease, and specifically single ventricles. Just to highlight the importance of his work, I know all of us don't feel it, but it's 75% of single ventricles survive to being 30 years of age. We are going to see these patients in adulthood. There's about 70,000 nationwide, worldwide, and that number is going to double in the next 20 years. And I think his work is instrumental in helping us assess how to evaluate these patients, and more importantly, how to improve their outcomes. Dr. Ghelani, so excited to have you here. Thank you very much.
Thank you, Dr. Shah, and thank you everybody for having me. I'm so excited to give this talk. I hope you can see my slide. It's good to see a couple of familiar faces on the list there. Although most of you I don't know. I'm a pediatric cardiologist, so our paths don't cross that much. But I'm going to try and cover MR imaging of the Fontan circulation with main objectives of understanding how MRI helps take care of these patients. To also briefly review the single ventricle physiology and palliation, given the the different levels of trainees and attendings in this audience, and as well I'll go through a couple of cases that I've done recently. Go through the pictures we've taken and see if we can view them together like a case and have some learning points. So with that, I'm going to go ahead and get started. I don't have any relevant disclosures. So single ventricles come in a variety of forms, as you all know. You could have hearts that have predominantly a right ventricle, like hypoplastic left heart syndrome, or double inlet, double outlet right ventricle. You could have an unbalanced AV canal with a big right ventricle and a small left heart. Or you could have LV dominant hearts like tricuspid atresia or double inlet LV or pulmonary atresia intact ventricular system. But what's common in all of them is that they have one functional pumping chamber, and hence they cannot survive without palliation, as you know. So the neonatal management in these patients is determined by the anatomy. For example, if there is systemic obstruction like hypoplastic left heart syndrome, the small aorta coarctation, then they undergo a Norwood operation with arch reconstruction and either a RV to PA conduit or a VT shunt. And this is a little bit important even when we take care of our adult patients, because when we are imaging them, you need to decide whether you want pictures of the arch or not. And when you see some scar on the RV, the history of having had an RV conduit is important, and so on. So that's the palliation if there is systemic obstruction in the neonatal period. Now, if there is no systemic obstruction, meaning no coarct, the body can perfuse just fine, then the next step is determined by whether the pulmonary blood flow is obstructed or not. If there is high pulmonary blood flow, for example, tricuspid atresia with large VSD, then you've got to put a band on the pulmonary artery to protect the lungs. And then subsequently, in a few months, you will do a Glenn. If there's low pulmonary blood flow, again, for example, pulmonary atresia or tricuspid atresia with small VSD, then your choices are either doing a BT shunt or a PDA stent to continue to supply the pulmonary blood flow. And in a few lucky cases, when there is balanced pulmonary blood flow, there is just the right amount of PS, you could get away without doing any neonatal procedures. You can, just follow them and, do a Glenn when they are 4 to 6 months of age. So like I said, we do a Glenn and a Fontan. This is a typical palliation pathway. In Glenn, you connect the SVC to the PAs, and in a Fontan, essentially, you get all the venous return to go into the lungs passively without a pump. there are many varieties and variations to the Fontan operation. The three most common types you're going to see in clinical practice are atriopulmonary Fontan, in which, as you can see here, the anatomy is kind of left as is, except the appendage of the right atrium is connected to the PA, and they close the ASD and the tricuspid valve. Hence, all the systemic venous return has to go through the appendage into the PAs. This was the original kind of commonly performed operation, but it's now recognized that patients with this anatomy or this kind of palliation have a lot of arrhythmias and inefficient Fontan circulation. You can imagine the path that the blood has to take, and this has mostly been abandoned. And lateral tunnel and extracardiac conduits are the two most common type of operations done these days. Now, in most centers, I think extracardiac conduit is the predominant surgery these days, although I will say at Boston Children's Hospital, we still have a slight preference, depending on the surgeon, for lateral tunnel Fontans. And I will say the jury is still out as to which has a better long-term outcome. I'll show you some slides on that. So as we know, Fontan patients have relatively good medium-term outcomes in terms of survival. For example, this left study from the US and this right study from Australia and New Zealand showed about 75 to 80% survival at about 20 years after a Fontan. This left chart also shows that those who have a dominant left ventricle in the blue line have better survival compared to those who have a right ventricle. Now, whether this is because it's a right ventricle or is it because right ventricle also is often associated with small ascending aorta and arch and the more complicated initial surgeries, it is still a little bit hard to tease apart. But nevertheless, those with functional right ventricles have worse outcomes than those with functional left ventricles. And on the right side, the graphs show the different kinds of Fontans in their registry here. And you can see the bottom line, the one with less survival, are the atriopulmonary Fontans. And on the top, extracardiac conduits and lateral tunnel are basically superimposed. But you can see that the lateral tunnel has a little longer follow-up because that is the surgery we started doing it first, and then extracardiac conduit is kind of a relatively newer modification. But you can see how the lines are basically superimposed. Although they have pretty good survival, and again, as you all know, they have a high morbidity. So here with a follow-up of about 20 years in this study, again from Australia and New Zealand registry, about 75 or 70% of patients have some late adverse event, be it arrhythmia, thrombosis, PLE, plastic bronchitis, and so on. And hence, it is very important to kind of risk stratify and identify patients who are at high risk of these kind of complications. And if complications happen, to identify them early. And MRI plays an important role in that. Components of a MR examination in a Fontan, we do cine imaging, we do flows, we assess for fibrosis, we do lymphatic imaging. Those are the four main components. Cine imaging shows us the anatomy. We can calculate mass, volume, function. We can look for obstructions along the way. Flows help us calculate valve regurgitation, aortopulmonary collateral flow, differential branch pulmonary artery flows, and so on. I did not put angiography here. I guess we do angiography sometimes with contrast, sometimes without. Again, just to assess the vascular size and adequacy. And fibrosis, we do discrete scars like late gadolinium enhancement and also diffuse fibrosis, estimated as extracellular volume fraction. And the last is lymphatic imaging. This is kind of new. We've started doing this in the last few years, but there are, given that this is a obligatory systemic venous hypertension kind of circulation, and that's where the thoracic duct and all the lymphatics have to drain, there is inherent abnormalities in lymphatic drainage, and we are only starting to understand the role that lymphatic system plays in all the complications that these patients have. So let's go into cine imaging. SSFP is kind of a bread and butter sequence where we look at pictures like this, 4-chamber view or long axis horizontal view, cine of the arch, short axis view for function, outflow tract views, and these are the kind of pictures we see. So with this, I'm going to switch gears and show you a case. This is a case of a 45-year-old woman who had a history of BT shunt, initially followed by a superior KO pulmonary anastomosis in 1991, followed by a Fontan operation in 1997. And the details are not known, making this kind of an unknown, although we knew some of the details. And she's generally well, she's followed in clinic every year, but she has some new symptoms of exercise intolerance. I'm going to stop sharing this screen and reshare my other screen. Is this okay? You able to see my MRI playing?
Yes.
Okay, great. So I'll start with this. Actually, I'll give you a overview of all the pictures we took in this patient. So, we did some survey images, as you can see here, non-moving, just rough, quick pictures. And then we did a bunch of cine images. This is like a two-chamber, this is aortic valve, short axis, and so on. And then we did a bunch of flows, and then we did some lymphatic imaging. She had gadolinium administered at one of her prior recent MRIs, so we did not do that and did not give gadolinium. But let's look at her axial stack and see what we can learn from it. So I'm going all the way in the abdomen. I'm going to start playing this. So you can right away see that the abdominal situs is not normal. You can see this is the stomach on the right side. There's a spleen with a big kind of cleft-like appearance on the right side. The liver is kind of midline. The aorta is in a relatively normal position, but instead of having an IVC somewhere here, there's this dilated vessel behind the aorta. So things just don't look quite right. And I'm going to scroll up from here and let's see if we can follow the vessels. So if you see this descending aorta, I'm going to go quickly up. It goes up, 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 and it goes rightwards. So it's a right aortic arch. You can quickly see that. If I follow this thing down, that's the ascending aorta. It's dilated. We go down. It makes it to the heart. So fine. We got the aorta sorted out. Now let's look at this this vessel here. I'm going to keep going up, up. Now there is a connection, some weird connection here. We'll come back to that. But if we keep following that vessel up, 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 going up, going up, going up, going up, up, and it has this little arch, right, on the other side of the aortic arch, and it enters this circle. And I'm going to, if you follow my pointer down, I'm going down, down, and there it goes into the PAs. That's the left pulmonary artery, and that's the right pulmonary artery. So that's interesting. This is a interrupted IVC with a left-sided azygous vein that is draining all the way up. I'm showing you that again, going all the way up into this right-sided SVC, which has been connected to the PAs. So what do we call this? When we have essentially a Glen in the setting of an interrupted IVC, we call it a Kawashima operation. There's nothing different. It's a superior cavopulmonary anastomosis in the setting of an interrupted IVC. And why is it important? It's important because it's essentially a Fontan, except for the hepatic venous return. Everything else is already making it into the lungs. So let's see what we did with the hepatic venous return in this case. So those are the hepatic veins, 1, 2, 3, multiple. I'm going up, up, and they would have drained to the heart originally, but see where they're going. They have been connected to this azygous vein by a conduit right here. And hence all the systemic venous return is making its way into the lung. So it is a Fontan physiology, although there's no Fontan conduit as such. Why do we do that? So you must have heard of the hepatic factor, and imagine we did a conventional kind of Fontan conduit from hepatic veins up into the PAs. Now, if we hook that hepatic veins up to the right of where the Glen is, then the chances are that all of that hepatic venous return is going to go to the right lung because there's so much other flow coming to the left side of this hepatic vein. And that's going to result in this hepatic factor not making it to the left lung. And that would result in pulmonary AVMs or arteriovenous malformations in the left lung. Now, hepatic factor is kind of it's an enigma. Nobody knows what it is, and whether it's addition of something or removal of something that the liver does. Having said that, we know that if we don't get the liver blood into the lungs, they get AVMs. So this was a way, way back in 1997, they decided to connect it to the azygous way that kind of ensures that it mixes with all the lower body blood, and at least some of this hepatic factor makes it into both lungs. And she's done remarkably well without any AVMs, and this thing has stayed patent since the beginning. So that's kind of a venous anatomy. If you look inside the heart, there are two AV valves, there are two ventricles. The squeeze of the heart seems okay, but we can look at it a little bit more in a short axis view. So let's look at that. This is the short axis image stack of images. This is how we measure our volumes. You can see the blue and red and green kind of popping in. I'll take that out, but this gives us an idea about ventricular size and function. The LV function is probably mildly depressed, but the RV doesn't look so happy. Both the ventricles eject into the aorta through this VSD. There is pulmonary atresia, and you can see a little jet of aortic regurgitation here. So, is this ventricle healthy, not healthy? How do we know what's going on? So we tend to report combined ventricular size and function. So we report them separately, but we add the two together. So the combined ventricular end diastolic volume in her case was 195 mL per meter square, which is very high. We've done a lot of analysis of our data, and end diastolic volume or ventricular size is the strongest risk factor we have for late mortality. And I'll show you some data on that, but 195 puts her at a high risk of subsequent events. And her combined ejection fraction was like 42%, so mildly depressed. We did some more cine imaging like this. The aorta is dilated 5.5 centimeters, the ascending aorta. Arch is unobstructed. You can see this AR. She's had moderate AR, about 25% when we measure it through our flow analysis. And then lastly, I'm going to show you her thoracic duct. So we do a sequence called T2 weighted imaging that gives us a good look at lymphatics. It's a water, where is the water kind of sequence. So it shows us the water, and you can see she has a right-sided thoracic duct that enters somewhere probably in this right innominate vein that she has. But it looks a little dilated and tortuous, and that may have some importance. So I'll show you some data that we've recently published about the importance of size and tortuosity of the thoracic duct. So with that, I'm going to stop sharing this and start sharing my other screen again. Okay, I hope you can see my slides now. So moving on again, continuing to discuss the cine imaging, ventricular dilation and dysfunction are the strongest risk factors. We did an analysis of 416 patients and with 14% death or transplant rate, and we found that end diastolic volume more than 156 index to BSA raised to 1.3 was basically the highest predictor when we did cart analysis to see which was the strongest discriminant. And then beyond that, those who had that dilation, global circumferential strain, here I'm showing the longitudinal strain, but global circumferential strain, less than -7 was protective, or like worse GCS was further discriminating for risk of death or transplantation. Further in cine imaging, we can look at vascular anatomy like this. If there was an obstruction, that would be easily identified on the cine imaging. And then also we can identify thrombi. So for example, in this patient in the right top, where my pointer is, you can see there's something in the Fontan pathway. It's most likely a thrombus, but we can confirm that in the bottom sequence here, which is a long inversion T1 sequence where we give an inversion pulse and make everything dark, but signal recovers at differential rates, and thrombus recovers the slowest. So if you let a lot of time go by, then thrombus remains dark as compared to myocardium and blood, and that gives us a very high confidence that it is a thrombus. So we can do some sequences like this to confirm that a given pathology is a thrombus or is it just a muscle bundle or some other etiology. Next, let's talk about AV valve regurgitation. It has been identified as one of the risk factors for death transplantation. In this study that I have on the screen from the Australia New Zealand registry, there was increased death or transplant risk with a hazard ratio of 2.8 over time. And also in the left bottom here, you can see that those who have a right ventricle have a higher cumulative incidence of significant AV valve regurgitation. So right ventricle kind of goes along with a lot of things, not just more dilation, but also more incidence of valve regurgitation, which adds to their risk of mortality. And we can quantify AV valve regurgitation by flow analysis. Essentially, we measure the amount of flow going into the ventricle, and you could compare it to the flow going out through the aorta, and then the difference is the regurgitation volume, and hence we can get a more accurate quantification of the regurgitation fraction. Talking more about flows, we assess branch pulmonary artery flows, and as you know, some of the patients, the aorta tends to get very big and compresses on either of the branch pulmonary arteries, sometimes the left pulmonary artery. So Rahul, who's my colleague in Boston, did this study. He looked at 147 patients and basically defined something called pulmonary artery flow maldistribution, meaning is there an imbalance of more than 20% in the two branch pulmonary arteries? And there were several kind of differences, but still statistically significant lower exercise capacity in those who had a pulmonary artery flow maldistribution compared to those who did not. I guess it makes sense if you're not able to augment your cardiac output with exercise because you have a resistor that we have to be mindful of that, especially in those who have a DKS anastomosis, a big ascending aorta pressing on that LPA. Next, aortopulmonary collateral flow. This cartoon is just to give you an idea as to how we calculate aortopulmonary collateral flow. Essentially, we look at all the pulmonary venous return and remove the branch pulmonary artery flow from it. So whatever came back to the heart, if it did not come through the PAs, it must have come from the APC. So that gives you a number. For example, in this patient, it was 0.9 liters per minute, which was about 25% of the total pulmonary venous return. And about 20% is kind of typical in a Fontan patients. And we are in the process of kind of writing up a manuscript. I'll show you some prelim data, but APC flows is one of the things that could be a modifiable risk factor. We do all these studies, we say ventricles dilated, you're going to die, but what are we going to do about it? So there are very few modifiable things, and this may end up being, something you can actually intervene on. We can also quantify APC flow on either lungs, by looking at that side's vein and arteries. And we can confirm our pulmonary artery and pulmonary vein difference findings by comparing our ascending aorta to our systemic venous return, meaning whatever went out of the ascending aorta should come back from the veins, and whatever does not must have gone to the lungs. And hence you can get a verification of your aortopulmonary collateral flow by comparing ascending aorta flow to the systemic venous return. This is one study from Canada that looked at 55 patients, and essentially they found that higher APC flow was related to a composite outcome of cardiac readmission, reintervention, Fontan failure, or arrhythmias. This is what I mentioned, we are looking at a larger cohort of 356 patients. Some of them had repeat measurements, so we could see the trend of APC flow. And preliminarily, we do have a higher APC flow and actually faster rising APC over serial MRIs associated with composite outcome of death or transplantation, as well as some secondary outcomes such as ascites and hemoptysis. So this is being written up right now. We will be presenting an abstract at AHA coming up in November on this. Yeah, I think we should have time. So we're going to go and look at case number 2. It'll take me 20 seconds to load that. So I'm going to stop sharing this. So the second case is a teenager, I think 17 or 18-year-old, who has hypoplastic left heart syndrome, mitral stenosis, and aortic stenosis, who's had a Fontan, but has some peculiar physiology that I want to share with you. Let me share my screen. Sorry, this dual screen and finding the correct button is a little challenging. Okay. Hopefully you can see this. So I'm going to start with this axial stack again for this patient. This looks pretty normal, right? You got stomach on the left, spleen on the left, liver on the right, IVC in its correct place, and a descending aorta pulsatile in its correct place. As I slide up, you see a more conventional, what we are used to seeing, kind of a Fontan. You see the hepatic veins come together into the IVC here. As I go further up, you can see it's a lateral tunnel. Although it's very difficult to say lateral tunnel versus extracardiac conduit. In this case, I know because I know the note, and that this was a lateral tunnel. And you can actually see there's a fenestration here. You can see a small jet of flow entering from the Fontan conduit into the atrium here. And as I go further up, that's the Fontan conduit up, 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 up. You can see the two branch pulmonary arteries. You can actually see the left pulmonary artery is a little bit compressed by this dilated ascending aorta there. And further up, you can see the left innominate and the right innominate veins. You can also see that the arch is unobstructed. He had hypoplastic left heart syndrome, and the arch was intervened upon. There is some, flow related signal here, but we looked at it in other views, and the arch was unobstructed. So we won't get too much into that. Here, the pulmonary veins are unobstructed, and it's a hypoplasia. You should make sure that the ASD is large, and there's a large ASD, so pulmonary venous return can make its way to the tricuspid valve without obstruction. You can see the right ventricle has pretty good function. In fact, the left ventricle seems to be squeezing okay as well. But let's look at some other views. So here in the right top, you can see the nice DKS anastomosis. This is right ventricle into the neo aorta. There's no neo AR. And again, good right ventricular function. Actually, I need to do this. Now in the right top, you can see the native aortic valve has some regurgitation. You can see the diastolic back jet coming down into the left ventricle here. Although the left ventricle seems to be squeezing pretty well. Here, right bottom, that's the aortic arch. You can see it doesn't have significant obstruction. It looks pretty uniform. And then in this left bottom picture here, that's ventricular size and function. You can see good systolic function for both the ventricles, except maybe for this right ventricular outflow tract, where he had a history of a sanoconduit when he was a child, and which you can also see in this middle bottom picture. There is a scar here. This is late gadolinium enhancement imaging. So dark is muscle, it's good. White is a scar. So that's the scar from the sanoconduit. But otherwise, the ventricles do not have any significant late gadolinium enhancement. But this patient has some aortic regurgitation. So let's look at what the flow in the native aortic valve looks like. So this red circle is the native aortic valve. The green circle is the neo aortic valve. And I can play the two. But this bottom curve shows the flow across the native aortic valve. So in systole, flow goes out of the native aortic valve, and in diastole, there is regurgitation. But what's interesting is that there's more backwards than forwards. So there is a net backwards flow of about 9 milliliters per beat through the native aortic valve. But that results in a circular shunt. Essentially, that regurgitation, because there is net backward flow in the LV, has to go back to the mitral valve and go in circles, and that's just inefficient circulation in this patient, which is unusual, but it's a source of volume load for this ventricle. So if I show this, let me see if there's anything else to show here. No, so I'll go back to my slides and show you a diagram of what that circular shunt looks like. Okay, so the numbers the cartoon I showed earlier was actually for this patient. So in this patient's anatomy, in systole, 1.1 liters goes out of the native ascending aorta, but in diastole, 1.8 comes back. essentially leaving 0.7 liters per minute to have to go net back through the mitral valve like that. And basically it crosses the ASD into the RV and then goes out. And this 0.7 liters per minute is essentially wasted effort for the ventricles, and it's a circulation. So over time, this has thankfully remained stable. But if this was progressive, the ventricles in the Fontan circulation have multiple sources of volume load. They have AV valve regurgitation, they have AR, they have APC flows. But this adds to the long-term insult on the ventricle and its health. And MRI is very useful in kind of quantifying the relative impact of all of these things. Now let's move on to lymphatic imaging. So there are two main ways in which we image the lymphatics. One is a routine sequence that we've been doing. We call it the T2-weighted respiratory gated spin echo sequence. This is basically like a MRCT sequence. If you're doing an abdominal CT for gallbladder, it's like that. It basically shows you where the water is. And you can get beautiful pictures like this. This is from a Fontan patient. You can see the entire length of the thoracic duct. You can see, and this is very classic, that in the left supraclavicular region, there is increased signal. This has been called type 1 lymphatic distribution. As you know, Children's Hospital of Philadelphia has been kind of a pioneer in all the lymphatic work, and they have published the risk factors for Fontan based on appearance of lymphatics on this T2-weighted imaging sequence. So this is type 1 lymphatic sequence, and then type 2, 3, and 4. Type 2 is when you see lymphatic or T2 signal in both supraclavicular regions. Type 3 is when you see it in the mediastinum, and type 4 is when you start to see in the lungs. And this was initially described for pre-Fontan MRI, so not in Fontans, but what they found was those who had type 3 or 4 were extremely poor Fontan candidates, and they were even not given the option sometimes, and in those that were offered a Fontan, they did very poorly. So having increased lymphatic signal in your mediastinum or parenchyma, lung parenchyma is a poor sign. We've been doing this regularly now, and we're looking at its importance in the Fontan patients themselves, because originally, as I said, it was described in pre-Fontans, and we have some data that I'll share. For example, this study, this was just published last month in JCMR. We looked at 189 Fontan patients and 36 tetralogy of patients as controls. We sought to measure, one of our questions was, how well can we see this thoracic duct when we are not even doing a dedicated sequence for it? So all of our patients get this vascular sequence called 3D-SSFP. And what we saw was in 2/3 of patients, we were able to see the thoracic duct either completely or nearly completely, which was actually amazing to us, that we could just go back and find all of their ducts, even though we were not looking for them. And then in those patients, we measured its tortuosity. Relatively kind of, we made it up, but two of us kind of did an inter-observer agreement, and we had this template, meaning if it matches this, we'll call it none. If it matches this, we'll call it mild. If it matches this, we'll call it moderate. And we had not perfect, but reasonable agreement. And we saw that the thoracic duct was more easily seen and was larger when we measured it at its largest in Fontans compared to tetralogy. And then this larger diameter was associated with PLE, and increased tortuosity was associated with worse NYHA functional class. Again, this is very prelim data based on non-dedicated thoracic duct imaging, but I'm sure there's much more to come from CHOP and other centers that have started doing this. Another way of imaging thoracic duct is DCMRL, or dynamic contrast magnetic resonance lymphangiography. This is an invasive procedure where you take a needle and inject gadolinium in a lymphatic system and see where it goes. And this has become the standard of care as the initial diagnostic test in patients who have lymphatic complications like PLE or plastic bronchitis. And many of these have become essentially treatable by interventions. A lot of these are being done at CHOP. So at our center, we have done these mostly for chylus effusions. We haven't really intervened a lot on plastic bronchitis and PLE as such. But for chronic chylus effusions, for example, in this patient, we did a DCMRL. The patient had, recurrent chronic left-sided effusions, and when we injected in the groin and looked at the contrast and where it went, we could actually identify its course and see where it spills into the left pleural cavity, and that corresponds with our invasive lymphangiography here that our IR folks did, and then they got rid of this side channel and the symptom resolved. This was extremely useful because if we didn't, this pre-op imaging or pre-procedure imaging was extremely useful because in this case we could do a selective side channel occlusion as opposed to occluding the entire thoracic duct. Because if this was not known, and if the IR docs had gone just above the branch and gotten rid of the thoracic duct, that may have made things worse. We always worry about where will the lymph go if we get rid of the thoracic duct. Is it going to now manifest as PLE? Is it going to manifest as something else? So, our tendency is to try and avoid gluing the thoracic duct and try to do a targeted intervention into a local branch or something like that. And this dynamic MRL provides a nice roadmap for the interventionalists to kind of plan that and even assess the candidacy before they go around poking big needles directly in their abdomen. Let's talk about fibrosis. Late gadolinium enhancement is associated with larger ventricles, lower EF, ventricular arrhythmia, but there haven't been very large studies that have associated them with like death or transplantation. We still continue to do LG imaging if they haven't had it in 8-10 years, but we've gotten so good at doing vascular anatomy without gadolinium that we have not been giving contrast just to do vascular anatomy. We will give gadolinium if they haven't had it in a while to assess for scar, or if there has been a change in their ventricular function since the last exam. We can also measure diffuse fibrosis, which is, when there is no scar, but there is ongoing, some myocardial stress in the circulation. And it has been shown in multiple studies that Fontan patients have higher extracellular volume fraction, meaning, increased intracellular space, increased space outside the myocytes, which corresponds with basically diffuse fibrosis. And although weak, but there was this significant correlations between higher extracellular volume fraction, a marker of diffuse fibrosis, and elevated end-diastolic pressure as well as Fontan pressures in this relatively small cohort of patients published a couple of years ago. The last set of techniques we do in MRI I'm going to go over are 4D flow and computational fluid dynamic modeling. 4D flow is a pretty technique. It has really found relatively limited uses in our, this technique has been around for 25 years and we still don't do it in every patient because the applications are still limited, but there are some specific states, especially in some Fontan anatomy, that they are very useful. So I'll illustrate two specific ways in which we have used this data. We can basically trace flow patterns from either hepatic veins to understand where the hepatic blood flow is going. We can measure shear stress and power loss and those kind of things and plan our Fontan revisions. So going into one of them, we have done this also, but this figure was prettier, so I'm going with this publication. This is one application where you want to ensure equal hepatic venous flow distribution, because if you don't have that, then the other side is going to get AVMs, like I mentioned. So in this untreated or baseline anatomy, you can see the Fontan conduit, the Glen, and the 4D flow predicted that basically all the IVC hepatic flow was going to the left lung and all the SVC flow was going to the right lung, because there was an interrupted kind of IVC. So what you have here is a situation where the right lung does not get the hepatic factor, hence has pulmonary AVMs. Then they performed virtual surgery. So top is the baseline, like I showed you. They did two potential virtual surgeries. They repositioned the Fontan conduit. So red is the original line, the center line of the Fontan conduit. They brought it a little medial virtually, and then they predicted where the hepatic flow would go. And there was a little more going to the right side, but still predominantly everything was going to the left side. And then they tried moving their SVC virtually, and that basically sent everything to the right side, and the left side did not get anything. But we could kind of titrate the positioning and get a percentage split, or at least predicted percentage split at baseline, and then also at kind of, estimated postprandial states and exercise states, and with just some guesswork numbers in there. So after doing this virtual surgery, they did a virtual cath, where they basically, what if they put a stent and basically straightened it out? And that seemed to kind of work very well with nearly equal distribution of the hepatic factor on both sides. So that's what they ended up doing, is stenting SVC to the Fontan, which was interesting. But the 4D flow analysis kind of helped them have more confidence that would be successful in getting the hepatic flow in the right side. This is still relatively new. We need to have validation, meaning we predict all this, but have we kind of done imaging after we did the surgery and proved to ourselves that what we are seeing actually happened? We are in the process of doing that. But this is interesting and hopefully has application in all our heterotaxy patients, especially with interrupted IVCs. The next application is, estimating energy loss, shear stress, and conduit size. So I had a patient recently that was undergoing, is a Fontan, I think 18-year-old, who was undergoing surgery for mitral valve repair because she had, moderate to severe MR. But at the same time, we were wondering if we should upsize her conduit. Her conduit was already 20 millimeters. It was an extracardiac conduit. But we were wondering if changing it would make her even a better physiology kind of state, minimize energy loss, shear stress, and so on. So they did this kind of modeling of her shape, and these are the flows from the MRI. And then they simulated a new 20 millimeter conduit that would be a position like this, or a 22 millimeter conduit. They estimated the power loss with existing anatomy, and then what it would be if you did a 20 millimeter conduit, 9% lower power loss in the rest state, and 35% lower power loss in a postprandial state. These are all estimated numbers, and we, as I said, we need to validate all this. But purely based on these kind of simulations, the surgeons decided to actually upsize her conduit. And I don't know if that was the right thing to do, really, because her conventional hemos were fine. But at least there's a trend towards doing these kind of analysis, and people are willing to kind of, do a surgery for that. We wouldn't have gone in to do it, but while we were there at the mitral valve, this was an easy enough thing to do. So surgeons chose to do it. Lastly, and this is close to heart because I kind of participate in our complex biventricular repair program at Boston Children's Hospital, where we review anybody who's being considered for a single ventricle circulation at our center or elsewhere, and see if there's any chance to kind of use the smaller ventricle either as a full BIV repair or as a 1.5 repair, wherein it does just the IVC pumping and so on. So we looked at our experience converting Fontan patients to BIV repairs, and the study was done a couple of years ago. At that time, we had 23 patients. And they were all kind of older teenagers. I didn't write the age here, but they were all older teenagers. Nobody was older than a teenager. They were older, like older children or teenagers. And Amongst them, 15 were actually having failing Fontan physiology, and this was done as a way to kind of improve them, while 8 were kind of doing relatively well and electively because the hearts looks so good with 2 ventricles and that we should just go ahead and do this kind of a situation. And some of them had intermediate procedures to do ventricular recruitment. For example, if there was a Fontan with a smallish left heart, but still promising, we would try to recruit the left ventricle by partially closing the ASD, doing some mitral valve work while leaving the VSD open, perhaps adding some extra pulmonary blood flow, maybe with a shunt or a RV to be a conduit, and then giving it some time, force feeding the left heart, and then taking down the Fontan and so on. So some of them had that ventricular recruitment procedures, but in the end, everybody who had in a short 2-year follow-up, everybody who had an elective takedown is surviving and doing well. Although amongst those who were failing Fontans in whom this was done to improve their physiology, there was some mortality, at 2 years. So this is still, kind of should be viewed on a case-to-case basis. It is feasible, but we need to learn and identify our patients better because there's a non-trivial mortality rate at 2 years, especially if you've taken somebody who's already kind of sick. So I think that is all I had for slides. I would like to thank everybody at BCH MRI group here that has helped me, especially Dr. Prakash and Dr. Rathur, who gave me many of my slides. And with that, I'm going to end and put up this slide and take any questions if there are.
Thank you so much. Does anyone have any questions? You can put them in this chat box, or you're welcome to unmute and ask the question. All right, so I'm going to ask a question. You talked about ventricular function assessment as a single ventricle, combining the two. Can you show us maybe on the first example how you traced it? Do you separate the RV and the LV separate? Do you measure it as one unit? Does that make sense, the question?
Yes, it does. We always measure them separate,
Okay.
and we add the numbers. We do want kind of people to know what the individual sizes are, just in case things like taking down Fontan or things like that are being considered. But and our report template has a section for left ventricle, right ventricle, and we'll fill those in. Even if it's like tricuspid atresia and a small RV, just an infundibulum, we will still add that volume as an RV volume, but also report their combined end diastolic volume and combined ejection fraction. And I think the combined number is what we would kind of regard and follow, as long as the 2 ventricles are both contributing to the systemic circulation. If it's an aortic atresia, if a ventricle is there but not contributing to the systemic circulation, we will not add it. But otherwise, yes, we would draw separate circles and separate contours for both ventricles.
And then do you just estimate, like if there's a VSD, you just kind of estimate that area?
Yes, we just put the lines together. So I can actually, my first patient that you asked, I think I share my screen. So in my first patient, like if there is septum, we would do this. But as we go up towards the base, we just put them on top of each other. So because there is no myocardium there. So if I make this like this is how our contours would look. This is RV, LV, and at the base where there is a VSD, they are just on top of each other. But my report, would mention this, and combine all 3 of them.
Awesome. And then the single ventricle global index. What are your thoughts on that in assessment? I guess my big picture is these patients are often sick. We're often trying to get them to transplantation, especially some of the adults. And EF is such a good way to list someone in a sense. And like you said, one side doesn't work as well. So how do you tell that story to someone? Yeah. So those are two questions. What are your thoughts on?
So,
Yeah.
single medical global function index that, the equation to calculate that function index, and I didn't put that slide in even because it has end-diastolic volume and systolic volume and mass. I think we are not great at measuring RV mass, although we report it. There is a lot of noise there, and it has not been proven to be kind of better than just the end-diastolic volume itself to predict adverse outcomes. So at this point in my mind, the strongest kind of MRI measurement that will tell you a patient is at high risk of adverse outcome is the end-diastolic volume. It will go along with the lower EF. They will correlate, they'll co-vary when you do an analysis plot. So EF is going to be depressed as well, if they're big and dilated. In terms of if there are two ventricles and if one is squeezing and one is not, I think effectively, if there's a large VSD and they're both kind of contributing to the systemic circulation, it's their combined EF is what you would go by, and their combined ventricular volumes is what you would go by, because that is what we have used in our analysis as well. So say there is an unbalanced AV canal, and the RV is 60 mLs per meter square, and LV is 120 mLs per meter square. We would view that as a single ventricle with a volume of 180 mLs per meter square, which is pretty big and shouldn't need that much end-diastolic volume. If it is doing that, it's for a reason, and that would, in my mind, be a marker that something's not right.
And then when you mentioned strain. Are you doing that on a 4-chamber in circle CVI, or that's echocardiography yeah? And yeah.
That's a good question, and this comes up every time. Even when we try to do any research study, and reviewers have questions about this all the time, because there is no good way. So we made it up, and others have made it up. So we have started clinically reporting strain by echo in single ventricles, but our mantra is ignore the septum if there is one. So say there's an unbalanced AV canal, we would go from the RV free wall to the LV free wall and just make it look like one big LV. It may be right or wrong, but at least if you do it that same way every time, it's reproducible and we can track changes. So in a 4-chamber view, that's how we would do it. Same with short axis. We would go just free wall, free wall, free wall, free wall all around, and go mid ventricle and do it by echo. And our echo reporting program now has fields for single ventricle apical 4-chamber strain, as well as single ventricle mid-ventricular short axis strain. And so within patients, we can track them over time. There's obviously no normative data or anything like that, but they're helpful in terms of tracking the patient. For MRI, we have only used it as a research tool, but we measure it the same way. Essentially ignore the septum as long as 2 ventricles are contributing. If it's a single ventricle, other ventricles not contributing, like mitral aortic atresia or tricuspid atresia and tiny VSD, then we would basically ignore the other ventricle.
And I'm gonna ask anyone diastolic function. You mentioned it was on the slide. Your thoughts?
I think diastolic function in Fontan's is going to be extremely challenging to measure by imaging. It's something that I want to try and tackle. In fact, I have a project that I'm trying to do right now, looking at strain rate, and how fast the tissue is moving. So in echo in normal hearts, right? The gold standard we have is tissue Doppler and E/A, like how fast the blood is moving and how fast the tissue is moving. Those are the 2 tools we have, and we come up with ratios and velocities with using those 2 numbers. And in Fontan's, we have that information by echo and MRI. There's no great kind of what is supposed to be normal, but we have a large data set of about 400 patients who've had MRI and nearly contemporaneous caths with Fontan pressures and filling pressures. So we have a project ongoing to try to kind of see if any of the MRI strain rate, velocity parameters and ratios kind of have any association and with the filling pressures. But right now, I mean, short of large scar or like clearly elevated diffuse fibrosis numbers, I don't know that there's a great imaging marker for diastolic dysfunction in Fontans.
It's complex, and pro-BNPs don't work very well to help in Fontans that I've noticed. Corey, you have a question, Dr. Tranquil?
Yeah, first of all, great talk. Really enjoyed it, and thank you for virtually visiting. We've got sort of an institutional interest in exercise CMR, and I noticed you had some really interesting stuff up there about power loss through the Fontan circuit in correlation with peak VO2, and so I'm wondering, we're sort of big believers, some of us, that in the standard adult population, giving that physiologic challenge can really unmask some things. Do you think that? Have you worked with this technique in your population? Do you think there's any space for that, or it would offer incremental value, or is it pathology so obvious that it might not?
I think that is absolutely necessary and great. I have zero experience. We don't have a ergometer that's MRI compatible. But I got a message like 3 days ago. I was part of a group message saying, "Hey, we may have some money lying around. Do you want to spend it on MR ergometer?" And all of us promptly responded saying yes, including Anne-Marie Valente. We're like, yes, we need it. So I think that's right. Lying flat on the bed and measuring this is very different from actually testing them. And personally, I think we sometimes, because I guess we like to see things, we overuse imaging and we underuse functional testing like exercise tests. That's going to tell us, I think that's going to tell us a lot more than a baseline at rest imaging test that we keep doing so often. So totally, yes, I think exercise challenge would be a great way to study patients.
And so you had that one slide where you're sizing the conduit and you had postprandial and exercise conditions. So those were all simulated, and do you have any idea how well they match?
They're kind of approximate simulated data.
Great, very interesting.
Like you said, it'll be great to have real data to validate all of that.
Great,
Sunil, it's Sal. Can you hear me okay?
Yes.
Hey, it's good to see you. Just a question: when you're doing differential pulmonary blood flow, are you looking at net flow generally in the PAs, and do you basically always trace the pulmonary veins to get a comparison of the two, or do you look at it in, is it always net, I guess, is my biggest question, and how do you validate that it's true?
Yeah, our texts don't allow this, but we get flows everywhere in all Fontans. And so, yes, we would get branch pulmonary artery flows, and we would report the differential antegrade pulmonary blood flow through the branch PAs. But we would also get pulmonary vein flows. So we would know the contribution from the pulmonary artery and from aortopulmonary collaterals. Whatever is not going through the LPA is the APC flow. And we have kind of a table that in our reports that mentions differential pulmonary artery blood flow and the relative contribution of APCs on each side, as well as combined together for the patient. And you can imagine if there is less LPA, the lung is going to develop more APCs, and sometimes the pulmonary vein flow doesn't reflect. They're often equal when there is significant maldistribution in the pulmonary arteries as a result of aortopulmonary collateral flow. So I think it is, in Fontan patients, I think it is important to measure pulmonary vein flows. I will say this could be inaccurate when there are systemic to pulmonary venous decompressing collaterals, because say some vein is decompressing SVC into a right upper pulmonary vein, then for MRI that might smell like an APC when it's not. So you got to make sure there are no large veno-venous collaterals when you're measuring APCs using pulmonary veins and pulmonary arteries.
Sal,
Thanks
can
so
I ask
much.
a quick follow-up to that? I think, Sal, one of the things that we've struggled with is when there's a lot of, and this isn't Fontan's, but if you have a lot of pulmonary regurgitation, which Fontan's don't, that you measure in the PA flows, do you use the net forward flows when you're calculating differential flows, or do you use the total forward flow?
In the set like tetralogy of flow, there'll be holodiastolic flow reversal in the branch pulmonary arteries in the setting of a transcendental patch or severe PR. But the net flow, meaning antegrade minus retrograde, will be pretty accurate in terms of how much flow is going to that lung. And that's what we use. And, this has been validated against lung perfusion scans done by nuclear medicine, which is kind of the gold standard if you don't have any intracardiac mixing. We've had pretty reproducible results. So irrespective of the degree of pulmonary regurgitation, your branch PA net flow should be accurate, because it's usually laminar, low velocity, nice circular vessel, and with reliable kind of velocities, and we get pretty reliable results.
Well, thank you so much for your presentation and your time.
You're welcome, and thank you everybody for your attention and for having me.